So this is part 2 of the neurologic disorders. And so I'm going to jump right into your disorders. So let's start with headaches. You can have vascular, tension, traction, or migraine headaches. And for your vascular headaches, these include migraine, cluster, and hypertensive headaches. Your tension headaches, they may arise from psychological problems related to tension or stress, or from medical problems such as cervical arthritis. Your traction inflammatory headaches, they include those caused by infection, intracranial or extracranial causes, and temporal arteritis. So your migraines, they are more common in women, and the onset is usually age 10 to 45. These patients often experience an aura, so they have a sensation or a smell that lets them know that a migraine is coming on. These are described as throbbing and pounding. And now your cluster headaches, they occur daily and are described as burning, sharp, and steady. And the onset is sudden and usually occur at the same time of day. And then for your tension headaches, they are more common in men. So you want to assess any initial signs and symptoms that occur before the headache. And you want to assess the changes in the ability to carry out ADLs. They can do a CT or an MRI. Medical management, you have dietary counseling. So you want to let them know that some foods may cause or worsen headaches, including tyramine, nitrates, or glutamates. So you want to instruct the patient to keep a food diary. Psychotherapy is counseling sessions that can help the patient develop awareness of stress factors and deal with pain. For medications, you're going to give pain medicines. You can give aspirin, beta blockers for your migraines. Your cluster headaches, you can give opioid analgesics. You can give acetaminophen, ibuprofen, aspirin. Nursing interventions are relaxation and rest, no alcohol, regular physical exercise, cold packs to the forehead, and identify any triggering factors. Next, you have neuropathic pain. This refers to pain originating from the peripheral or central nervous system caused by direct stimulation of the myelinated nervous tissue. It is characterized as a tingling or burning pain in the area of sensory loss. It may result from post-therapeutic neuralgia, diabetic neuropathies, trigeminal neuralgia, and phantom limb pain. And pain that is described as unbearable and does not respond to treatment is classified as intractable. So for your assessment, again, you want to assess their pain, assess their ability to carry out ADLs, any muscle weakness. You can do the electrical stimulation and psychological testing for your diagnostic test. Medical management, you have your TENS unit, spinal cord stimulation, acupuncture, nerve block. You can give gabapentin, that's going to help with the nerve pain. Tegretol. And for nursing interventions, you want to give comfort measures, give a stool softener to prevent straining, offer prune juice and a high fiber diet, and promote relaxation and rest. So increased intracranial pressure. This is ICP. This is one of your major disorders. So this is a complex grouping of events that occurs because of multiple neurologic conditions. It often occurs suddenly, progresses rapidly, and requires surgical intervention. This occurs in patients with brain tumors, hemorrhage, anoxic brain injury, and toxic or viral encephalopathies. And it is commonly associated with head injury. And so the Monroe-Kelly doctrine, it's basically stating that an increase in any constitute must be accompanied by a decrease in one of the others, or else the ICP is going to result. And as a result of the ICP, it increases within the cranial cavity. It is first compensated for by venous compression and cerebral spinal fluid displacement. And the life-sustaining mechanisms of consciousness, BP, pulse, respiration, and temperature regulation all become impaired. So that's just saying that things are happening because of the ICP. You're going to have loss of consciousness, your BP, your pulse, your vital signs, they're going to become impaired. One of the things that happens is called Cushing's response. This is the widening pulse pressure. This is increased systolic blood pressure, deepening irregular respirations, and bradycardia. So this is going to let you know that the patient is experiencing ICP. So for your assessment, you want to first assess the level of consciousness, disorientation, restlessness, and lethargy. If the patient's having visual changes, headache that occurs with increased ICP usually increases in intensity with coughing, straining, stool, or stooping. They may have sluggish pupillary response. We have what's called ipsilateral pupil. This is when the lesion is in one hemisphere. It remains dilated and is incapable of constricting. You have a blown pupil, which is a pupil that is fixed and dilated. And you have anascoria, which are unequal pupils. They may have ataxic breathing, which is irregular and unpredictable breathing pattern with random shallow and deep breaths and occasional pauses. They're going to have a positive Babinski's reflex. Hyperflexia and rigidity are additional signs. The vomit is projectile. They can have papilledema, also called a choke disc. So as the optic disc becomes edematous, the retina is compressed and cannot detect light rays. So visual acuity is lessened as the blind spot enlarges. They may be within two positions, the decorticate and decerebrate. In the decorticate, that is the flexion of the arms, wrists, and fingers with adduction of the upper extremities and internal rotation and plantar flexion of the lower extremities. You have the decerebrate, which is all four extremities are in rigid extension with hyperpronation of the forearms and plantar extension of the feet. So here is a picture of the Babinski. So if it's negative, the toes are going to curl. And if it's positive, they're going to dorsiflex and they're going to have like a fanned finger shape sign. Your two positionings here, your decorticate. This is a mnemonic to help you remember the posture. So the arms are like a C. So like in the word decorticate, it has the two C's. And in decerebrate, it is extension and the arms are like E's. So I'll give you a second to look at that. Okay. Your diagnostic test, the goals are to treat the underlying cause of increased ICP. You want to ensure adequate oxygenation to support brain function. They can do mechanical decompression with craniotomy or craniectomy. And the physician will order a stat dilantin level. If abnormal, they're going to give volume. And the therapeutic level should be between 10 to 20. So if it's below 10 or above 20, we're going to know that the dilantin isn't working or they're having toxicity or something's going on. So you have three main categories of medications that are going to treat ICP. These are osmotic diuretics, corticosteroids, and anticonvulsants. So you have your mannitol, you have Decredon, and Dilantin are the drugs to remember. Your nursing interventions. So you want to reduce venous volume. So you want to elevate the head of the bed. You want to make sure to place the neck in a neutral position, not flexed or extended. Position the patient to avoid flexion of the hips, the waist, and the neck, and rotation of head, especially to the right. Avoid isometric or resistive exercises. Avoid enemas and laxatives. You want to have a Foley catheter in place. You want to perform suctioning only as necessary and for no longer than 10 seconds. You can administer oxygen and you can use a hypothermia blanket to control body temperature. Next is disturbances in muscle tone and motor function. So motor function disturbances are the most commonly encountered neurologic signs and symptoms. So this is damage to the nervous system that often causes serious problems in mobility. So injury of motor neurons result in alterations of muscle strength, tone, and reflex activity. Muscle tone can be described as flaccid or hyperreflexic. So with flaccid, they're going to be weak, soft, flabby, and lacking normal muscle tone. And with hyperreflexit, it's going to be excessive reflex responses. So again, you want to assess abnormal gait, any changes in the ability to carry out ADLs. They can do in EMG. And for your medical management, you can give muscle relaxants such as baclofen. Nursing interventions are going to be safety, so you want to make sure that they're not falling, make sure their arms aren't hanging over the side of the wheelchair. You're going to inspect their skin, rotate every 2 hours. If they have hemiplegia, which is paralysis on one side of the body, the affected upper extremity is pulled inward at the shoulder joint and the wrist drops. If it's in the lower extremity, the knee flexes and the foot drops. So foot boards may be used to prevent foot drop, and the prone position is excellent for patients who are able to tolerate it. You want to encourage range of motion exercises. You can use Velcro assisted devices and help the patient see that there is life after disability. So for their nutritional needs, you want to avoid foods that can cause choking. Check the affected side for accumulation of food. Don't mix liquids and solid foods together. Encourage the patient to take small bites. Add a thickening agent or thicket to liquids. Sit the patient at a 90-degree angle with the head up and the chin slightly tucked, and you want to avoid straws. Next, we have disturbed sensory and perceptual function. So this is where the parietal cortex is the major importance in the interpretation of sensations. So any loss of that, you're going to have difficulty in daily functioning. The sensory loss can affect proprioception, that is the body's innate spatial sense. You can have what's called agnosia, which is the total or partial loss as a result of organic brain damage of the ability to recognize familiar objects by sight, touch, or hearing, to recognize familiar people through sensory stimuli. So you want to assess if they have any feelings of numbness and tingling. You're going to note the patient's ability to perform purposeful movements or to recognize familiar objects. Medical management will be determined by the underlying cause of the alteration in muscle tone and motor function. And your nursing interventions are going to be protective measures. You want to help the patient learn to inspect parts of the body that have no feeling or to protect sensitive body parts from the discomfort of linen rubbing over them. Another major disorder we have is epilepsy or seizures. So seizure activity is the result of abnormal electrical activity within the brain, and it can be caused from severe elevation in body temperature, drug use, electrolyte imbalance, brain tumors, brain infection, or epilepsy. So your seizure is more of an acute thing, and your epilepsy is going to be more chronic. So this is a group of neurologic disorders characterized by recurrent episodes that may include convulsive seizure, sensory disturbances, abnormal behavior, and changes in level of consciousness. Your clinical manifestations, so after their seizure, they're going to go into a rest period called the postical period. And we have something that's called status epilepticus. This is when recurrent generalized seizure activity occurs at such frequency that full consciousness is not regained between seizures. So repeated seizures cause the brain to use more energy than can be supplied, and the neurons become exhausted and cease to function, which may result in permanent brain damage or death. And the most common cause of status epilepticus is sudden withdrawal of anticonvulsant medications. So this is just saying that, after the patient has the seizure, they go into the rest period. But if they don't rest and they keep on having seizures in between, the brain's not going to be able to keep up with it. So it could lead to permanent brain damage or death. So you want to assess if they have an aura. You want to assess the number of seizures occurring within specific time, the character of it, duration, describe the patient's movements, if there were any cries or sounds made, what's their level of alertness. Diagnostic tests, they can do an EEG, CT, MRI, or blood test. So medical management, the drug of choice is Dilantin, and you want to note that Dilantin does have toxic effects such as ataxia, nystagmus, drowsiness, rash and fever, gum hypertrophy, and lymphadenopathy. So your nursing interventions, number one, never leave the patient alone. You want to lower them to the floor away from furniture. Support and protect the head. Loosen any restrictive clothing around the neck. Don't try to restrain the patient. Don't put any objects in the mouth. Give oxygen after the seizure. You can have padded side rails up. Observe and record details of the event. Note what events preceded the seizure. When did it occur? How long did each phase last? And what occurred during each phase? Next, we have multiple sclerosis. This is known as demyelination. This is a chronic progressive degenerative neurologic disease. The cause is unknown. And this is where your delta T cells start to attack the body and myelin damage occurs. MS is 5 times more prevalent in cold temperature states. The myelin sheath and sheath cells are destroyed, causing an interruption or distortion of the nerve impulse so that it is slowed or blocked. Clinical manifestations, the onset is insidious and gradual. They can have visual problems, urinary incontinence, fatigue, weakness, incoordination of an extremity, sexual problems, impotence, and swallowing difficulties. And this disease is characterized by progressive deterioration in some and remissions and exacerbations in others. And those may be related to fatigue, chilling, or emotional disturbances. So you want to assess for any eye problems, weakness and numbness, emotional instability, fatigue, nystagmus, changes in gait, and poorly articulated speech. There is no definitive diagnostic test, but they can examine the CSF. They can do a CT scan. Your medical management is corticosteroids such as prednisone and dexamethasone, which are going to help resolve the episode more rapidly. You can also give urocholine, which is a cholinergic. Your nursing interventions, well-balanced diet with high fiber foods and adequate fluids. You want to check skincare, water exercise such as swimming is encouraged. You want to avoid hot baths and promote a peaceful and relaxed environment. Next is Parkinson's disease, and this is known as a decrease in dopamine and an increase in acetylcholine. So they're going to have bradykinesia. They may have damage or loss of the dopamine-producing cells. Parkinson-like symptoms have occurred after intoxication of a variety of chemicals, including carbon monoxide and manganese. You have what's called drug-induced Parkinsonism, which can follow therapy with selected antipsychotic medications. And other factors include reduced estrogen levels and exposure to pesticides. So for your clinical manifestations, they're going to have a propulsive gait, and they're going to have the trio of tremor, rigidity, and bradykinesia. So with tremor, they're more prominent at rest, but disappears when the patient moves. It is aggregated by emotional stress or increased concentration. The hand tremor is described as pill rolling because the thumb and forefinger appear to move in a rotary fashion. You have rigidity, which is increased resistance to passive motion when the limbs are moved through their range of motion. And you have bradykinesia, which is automatic movements that are involuntary and occur subconsciously. They include blinking of the eyelids, swinging in the arms while walking, and swallowing saliva. They have a stooped posture, masked face, drooling, shuffling gait. And they have micrographia, where the handwriting samples become tiny and different. So you want to assess their emotional instability, any anxiety, depression, heat intolerance, difficulty speaking or swallowing. Diagnostics, they can do a CT or EEG. Your medical management. So you have levodopa, and you have the drug of choice, which is cardopa, levodopa, which is together is called Sinemet. And with this, you want to remember that it increases levels of dopamine and levodopamine. You want to give it with food, and you want to monitor your blood glucose levels. They can do what's called a drug holiday, and this is where all drugs are withdrawn, then restarted in smaller doses. Your nursing interventions. So you want to pay special attention to posture. You can lay on a firm bed without a pillow, may help prevent the spine from bending forward. Holding the hands folded behind the back and when walking may help keep the spine erect and prevent the arms from falling stiffly at the sides. You want to remember to do not hurry the patient. For food, it should be cut in bite-sized pieces before it is served, and drooling can become a problem, so keep extra tissue in their pockets. Chronic constipation may be a concern, so the patient should eat high fiber and roughage for bulk. Our next disease is Alzheimer's. This is AD. It's a chronic progressive degenerative disorder that affects the cells of the brain and causes impaired intellectual functioning. The neurofibrillary tangles. So regular physical activity, leisure activities, and antioxidant containing foods may lower the risk of developing AD. It's divided into 4 stages. In stage 1, this is where they have mild memory loss, their attention span is decreased, depression may occur. The most important thing about stage 2 is you have what's called sundowning. This is a specific type of agitation where the patient becomes more confused and agitated in the late afternoon or evening. So they start to not be able to recognize familiar faces, places, and objects. They have a loss of impulse control. Stage 3, total disorientation to person, place, and time. They have motor problems such as apraxia. They have visual agnosia and dysgraphia. So they have an inability to carry out learned sequential movements. They have an inability to recognize objects by sight, and they have difficulty communicating via writing. And in the 4th stage, this is the terminal stage where severe and mental physical deterioration is present and total incontinence is common. So you want to assess memory loss. Diagnostic tests. The diagnosis can be confirmed only at time of autopsy. So your drugs of choice are Aricept and Namenda. And with Aricept, you want to remember that the side effects are diarrhea, nausea and vomiting, headache. You want to give this in the evening, and you want to hold if the patient has diarrhea. Your Memantine, which is Namenda, it is used for moderate to severe AD. So they're going to start off with Aricept, and if that doesn't work, they're going to move on to Namenda. So your nursing interventions, you want to give finger foods, let the patient eat while talking, monitor disruptive behavior, and promote safety measures. Next, we have Myasthenia Gravis. This is known as muscle weakness. It's caused by an autoimmune process. And patients with MG have only about 1/3 as many acetylcholine receptors at the neuromuscular junction. So clinical manifestation is going to be muscle weakness. It can become so severe that the patient cannot breathe without mechanical ventilation. So you want to assess any ptosis of the eye, weight loss, if there are swallowing problems. For the diagnostic test, you want to have the patient look upward for 2 to 3 minutes. If the problem is MG, the eyelids will droop so that the person can barely keep the eyes open. They can also do an EMG. They can do the Tensilon, a short-acting cholinesterase inhibitor that is administered IV. Medical management, anticholinesterase drugs. They can do plasmapheresis, which separates plasma from the blood. So this removes the antibodies produced by the autoimmune response. They can do a thymectomy, which is an excision of the thymus that may reduce symptoms, and patient may require mechanical ventilation. Their nursing interventions are for aspiration precautions, minimal energy is used for activities, avoid crowds in flu and cold seasons, and taking medication before eating or engaging in activities to obtain maximum relief. You have next the amyotrophic lateral sclerosis. This is known as ALS. This is loss of both upper and lower motor neurons. It is a rare progressive neurologic disease that usually leads to death in 2 to 6 years. Your clinical manifestations are a weakness of the upper extremities, with the hands being affected first. Weakness may begin in the legs also. They're going to have dysarthria, dysphagia, and death usually results from respiratory tract infection. And the patient remains cognitively intact while wasting away. So they have what's called riluzole. This slows the progression of ALS and can add 3 months or more to the patient's life. And for your nursing interventions, you want to support the patient's cognitive and emotional functions. Huntington's disease. This is a genetic disease. This is where the offspring has 50% risk of inheriting it. It is known as too much dopamine. You have abnormal excessive involuntary movements called chorea. These are writhing, twisting movements of the face, limb, and body, deterioration in mental function. They're going to have psychotic behaviors. Your medical management is antipsychotics such as haloperidol. You want to give 4,000 to 5,000 calories a day, and you want to let them know that genetic counseling is important. So this is going to end part 2 of the disorders. Go ahead and click on part 3 and we'll finish up with the rest of the disorders for the neurologic system.